Hello and welcome to Health Professional Radio. I'm your host, Neal Howard. Thank you for joining us today. Our guest is Dr. Ajjai Alva from the Michigan Medicine Urology and Oncology Clinic, and he's joined us today to discuss a very recent FDA approval of a treatment that uses the body's own immune system against bladder cancer. Welcome to Health Professional Radio, Dr. Alva.
Thanks for having me on the radio program. This is a very important service to disseminate new and updated information to patients, providers, and patient family members, as well as to the community as a whole. As you pointed out, immunotherapy as a class has offered us and is continuing to offer us going forward a new toolbox to attack cancer. For the longest time, we had for advanced cancer of any type, basically chemotherapy. It was considered immunotherapy would not work, and it did not work in the old version of it, except for a few exceptions, which including in bladder cancer. There was one exception where intravesical or instilled into the bladder BCG, the same bacteria, the TB bacteria which has been inactivated, that provoked the immune response and is still being used, is still the standard of care for low-grade and very low-stage bladder cancer, which is strictly in the bladder only, which is a urology problem.
Well, I was wondering if there was anything that was contributing to the immune system's, I guess, enhanced ability to fight bladder cancer. We have an immune system anyway that's going to fight, in bladder infections and things of that nature. But when it comes to bladder cancer, what is it about the immune system that makes this treatment so special?
That's an excellent question. We have always known that some cancer types are more susceptible to an immune therapy approach, and those used to be typically or classically kidney cancer and melanoma, and they're still very responsive to immunotherapies. But bladder cancer, in a way, if you consider BCG, and all of us do, as immune responsive treatment, bladder cancer also has been one of those early cancer types that were always more likely to respond to immunotherapy. Part of the biology beyond that is that these cancers have a high rate of what we call mutations, changes in the DNA that are abnormal from what the patient is born with. So these changes in the DNA, we call them mutations. There are several classes of these changes. Some are just substitutions of the code letter, as we know, nucleotide code letters. Some are bigger changes with whole chromosomes being rearranged, inverted, deleted, anything and all of those copy numbers, multiple copies, more than should be. And all those changes, basically, to simplify it to a broader audience, would introduce a signal of non-self, a red flag, so to speak, to the immune system that I don't belong here or I'm not normal, which the immune system would then track down and attack. Now, the tumor, on the other hand, has a riposte to this one, as a counter. What it does is it's hide by camouflage, so to speak. It puts up signals which turn off the immune system, which gets close to it to attack. And one of the main turn-off signals is something called the PD-1, PD-L1 interaction. So PD-L1 is a protein, an antigen that is expressed on multiple tumor types, multiple cancers, including bladder cancer, and that hooks up with the PD-1 corresponding receptor to the PD-L1, which is expressed, among other cells, on immune cells, lymphocytes, so to speak, T lymphocytes to be precise. And so the immune cells are defanged or inactivated by this interaction. And that is what is keeping the immune system from attacking the bladder cancer. So the default is ongoing, but the brakes on the system are the PD-1, PD-L1 interaction. Now, the drugs that have recently been approved, there are actually, believe it or not, 5 drugs now, 5 different drugs, but working on the same PD-1, PD-L1 interaction to take off the brakes, so to speak, in the immune system so that the immune cells are not inactivated and therefore can go on and attack the cancer and mount a trigger immune response. There are now 5 different drugs in that class. So I think immune therapy has come of age in multiple cancer types, including in bladder cancer. It's here to stay.
Does this treatment strengthen the immune system in the area of detecting and combating bladder cancer while maybe weakening it in other areas? Or is this something that, like, as you say, the brakes just need to be taken off so it can do its job for the bladder cancer, but still protect us from all the other things that are attacking our body?
That's a good point, and we tend to think about immune system as one monolith. It isn't true. There are different segments of the army, so to speak, of the immune system army that deal with different threats. As you would think in any military context, there are many different divisions of the immune system. The anti-cancer division, so to speak, is very distinct from antibacterial, for example, immune system. So the paths don't overlap as far as we have seen in the clinical context too. This taking of the brakes by this checkpoint immunotherapy, as we call these, because these brakes are called checkpoints, immune checkpoints, and taking of the brakes by blocking the PD-1, PD-L1 interaction has so far not been known to increase the susceptibilities of infections as such, although infections have been reported in the context of patients treated on these drugs, but it is not known whether there is a causal effect. On the other hand, the common serious toxicities that we notice with these classes of drugs are those that you could predict would come from an overactive immune system, all along the lines of immune-mediated toxicities or autoimmune conditions. Mm-hmm. Now, autoimmune conditions, we think of rheumatoid arthritis or lupus erythematosus, SLE as it is called. These ones tend to be immune-mediated and flow from the mechanism of action of these drugs. So, for example, immune-mediated attack mounted against normal tissues, against lungs, for example, pneumonitis, as we call it, inflammation of the lungs, which manifests itself as dry cough or shortness of breath on exertion, especially. And now these are common symptoms of one of many different things, and the clinician's job is to have a high index of suspicion that this could be from the treatment, such as the anti-PD or anti-PD-L1, and then work it up appropriately. And the treatment would be, of course, very simple in most cases, which is switching off the system a little bit to cool it down. So it's like an overheated engine, for example. You give it a little time to cool down, and we could almost always resume, except for very serious immune-mediated toxicities, resume therapy once the immune system is cooled down and the attack against the normal organs has stopped.
Although FDA approved, is this treatment cost-effective for, the regular person? Is it available, say, through most insurances, Medicare, Medicaid, things of that nature, or is it something that still has to be paid out of pocket by those who seek to use it?
That's another excellent question. Of course, it does not pertain just to the biology of therapy, but to healthcare delivery and insurance, of course. These 5 drugs are FDA approved for use in bladder cancer, some in patients who have progressed on prior chemotherapy. A couple of them have been approved for use in patients who are not candidates or not fit enough to go through one kind of chemotherapy called cisplatin, which is usually the preferred drug in bladder cancer. So these drugs are approved by the FDA and therefore covered by Medicare, for example, and most health insurances. Of course, the fine print and the copay out of pocket and all those are very complicated and are evolving, so to speak. So these are now considered standard therapies.
Now, where can we go and get more information about this brand new FDA-approved treatment for bladder cancer, and a little bit more about you and the University of Michigan?
So, Neal, the approval are all posted on the FDA website or the cancer.gov.gov, which is a NCI website on each of these drugs, as well as are incorporated now in the NCCN, which is the National Comprehensive Cancer Network.org guidelines for bladder cancer. And NCCN is often the first resource for practicing physicians, as well as there is a patient version of the NCCN guidelines for use by patients and family members. So more information is available all these sites. At michiganmedicine.org, there are it's our link to our homepage at the University of Michigan with links to our bladder cancer program, as well as to our larger urological oncology program, including surgery, radiation, and medical oncology. That's an important distinction because these immunotherapy drugs, although they have been started out in the widely metastatic stage 4 bladder cancer, are quickly moving and being evaluated as we speak in the BCG refractory or resistant and early stages of disease too, prior to metastasis, as well as in after surgery, for example, or before surgery. There's ongoing studies, including here at the University of Michigan, evaluating the same drugs in those particular contexts.
Some great information. I'm glad that you came in and talked with us today. Dr. Ajjai Alva, medical oncologist at the University of Michigan, specializing in genitourinary cancers of the bladder, kidney, and prostate. We've been talking about a recently approved treatment for bladder cancer that uses the body's own immune system in order to combat the disease. Transcripts and audio of this program are available at healthprofessionalradio.com.au. You can also subscribe to this podcast on iTunes, listen in at hpr.fm, and download at SoundCloud.